All right, ladies and gentlemen, we are going to get started. And we're going to get started, I guess, a little bit early so that we can get you out of here early. Depends on how many questions you have. My name is Sam Watts. I am a board member at the Canadian Alliance to End Homelessness. I also serve on the National Housing Council. I'm currently the chair of Canada's very first review panel into the financialization of purpose-built rental housing. Say that 10 times fast. As I said yesterday, try saying it in French 10 times fast. But malheureusement, aujourd'hui, we don't have simultaneous translation here in this room, so the presentations will be in English. We're going to have roughly 1 hour of presentation and then a half an hour of Q&A. But I want to start off by acknowledging the land that we're on, that we're meeting on, because we've just sort of started into a new meeting. Didn't we have a fabulous opening this morning? Wasn't that energetic? I mean, amazing stuff. We've had such good openings to our plenaries, and so I'm so pleased that the people of Halifax have welcomed us. But here we are on land that's unceded, the Mi'kmaq territory, and we need to acknowledge and recognize the ancestral traditions, the things that we can learn, the ways in which we can work as communities towards reconciliation. And it's very much an important two-way street, isn't it? So I want to make sure that we all recognize and acknowledge that. Our setup this morning, if you were in the plenary, is perfect for this session. Talking advocacy. So I live and work in Montreal, and so I spend a fair amount of time doing advocacy work in the Montreal context and in Quebec. It's not unusual for me to speak to a minister in the provincial government or municipal or federal government during the course of the day, and of course on the National Housing Council I serve at the pleasure of the minister, which means that if I'm a real jerk he could get rid of me. So we'll see. But that's so far so good, by the way. But advocacy is critically important. Do you all believe that? Yeah. So that's why you're here, right? Otherwise you wouldn't be here for this particular session. So how do we do advocacy in an interesting way that's impactful? We have 3 presentations that we're going to get to hear. I think they're all terrific presentations. I had a chance to look at them briefly when they were uploaded to the site, so unless you've changed it. But so we're going to just do the presentations one after the other, and then what we're going to do is take some questions. And the key thing is, because we are recording these sessions, we want to make sure that we hear your question. So we're going to make sure that those questions get heard so that they can be properly recorded. And so I'd ask you to make sure that you wait for my signal before you ask the question, so that we can ensure that you're heard. I don't know if we have a roving microphone, but if we do, we do. So we're gonna make sure that you get the talking stick, okay? When you've got the talking stick, then you can ask your question. And the panel, I'm sure, will be more than happy to respond to your questions. So are we all good? Then let's get rolling. First presentation, I'm gonna ask the presenters to introduce themselves. I don't do long, flowery bios, but if you have a long, flowery bio, then by all means, go ahead. So. Please welcome our very first presenters.
Hi, everyone. My name's Olivia. I'm a social worker from Hamilton, and we'll have Kimmy introduce herself when she does her half of the presentation. But our presentation today is about maximizing the impact of policy advocacy efforts in the houseless serving sector. So for today's agenda, we're going to look over learning objectives. We'll go over our working group goals. We'll talk about how to convene a call to action. We'll talk about how to effectively engage with the media, how to write a press release, how to write an effective delegation and opinion piece, and then we'll also talk about what's next for our group. So our learning objectives for today. So to construct advocacy and campaign strategies for social change, to demonstrate how to challenge prevailing narratives, to reduce stigma and maximize the impact of policy advocacy efforts, and to acquire knowledge in the implementation of harm reduction models within shelter settings. So who is the Hamilton Harm Reduction Working Group? So we are a group of frontline workers and people with lived and living experience working towards addressing areas that are causing harm in all shelter systems. Our group was born from the community drug dialogue called Integrating Best Practices of Harm Reduction in the Shelter to Maximize Health and Safety of Service Users Who Use Drugs and Frontline Workers. This dialogue was hosted by the Canadian Drug Policy Coalition, Getting to Tomorrow, Ending the Overdose Crisis. So our overarching goal is for evidence-based harm reduction measures to be implemented across the shelter system in Hamilton to increase the probability of better long-term outcomes, specifically securing housing. So our two main goals that we've been working on is to implement safer use spaces in shelters and to remove all service restrictions related to drug use and carrying harm reduction supplies, as staff should be focusing on problematic behaviors and not the drug use itself. So, convening a call to action. Before we talk about how to do this, we just wanted to ask everybody to engage in a visualization exercise. So if you can imagine the most pressing housing issue that weighs heavy on your heart in your municipality, and keep this on your mind while we're discussing how to engage in effective advocacy strategies throughout the remainder of the presentation. So how do you initiate a call to action? The first thing you want to do is identify a local issue. So in our community, there had been an increase in deaths from drug poisonings in shelters, specifically 5 deaths at a local shelter in under 3 months. The next thing you want to do is understand who all the key stakeholders are. And then the next step is the process. So the first thing that our group did, we had a member of the harm reduction working group with lived experience sent a letter to City Council and the Mayor that outlined his personal experiences and included relevant data and research, with a call on the municipal government to immediately act according to peer-reviewed public health data and implement a safer use space at a local shelter to prevent further loss of life, with a request to meet within 2 weeks to discuss solutions. So this letter that we had written led to some meetings with City Council, the Manager of Housing and Homelessness, and Public Health to work together to develop short and long-term goals. So the remainder of the process will kind of go through throughout the presentation, but we first wanted to highlight the 2 successful outcomes that came from convening a call to action. So the first outcome was our group had the opportunity to co-draft a motion that was submitted for a general harm reduction framework in the community, including safer use spaces in shelter. This motion was unanimously passed at the Board of Health meeting, and this resulted in the creation of the Opioid Action Plan. And the second outcome was that we had an opportunity to provide feedback on shelter standards, specifically harm reduction policy and practice, filling a gap of expertise that was missing in the policy writing team within the city. So now we'll kind of break down the rest of the process step by step. So how do you effectively engage with the media? So the first thing you want to do is be prepared. So you want to understand the issue thoroughly, including both sides of the argument. You'll also want to develop 3 to 5 key messages that you want to convey in the interview. Short, relevant phrases are more likely to be quoted in media coverage, so always keep that in mind. You'll also want to gather relevant facts, statistics, and evidence that is up to date to support your key messages. It's also a really great idea to compile a list of potentially challenging questions that you might be asked and how you would respond to those. And you can always practice by conducting mock interviews with a colleague to refine your messaging and delivery. It's also really important to know your audience and tailor the message to their demographics and interests. So you'll want to craft your message in a relatable way with language that is accessible to a broad audience. You want to try to avoid jargon. And always stick to your key messages. So identify your key talking points and try to stay focused on them. And always transition back to your main point if the conversation goes off topic or if you're faced with a challenging question. Reporters often ask if there's anything else you would like to add at the end of the interview, which is a really great opportunity to reiterate those key messages that you really want to get across. And always treat the interview and opponents with respect, even if you strongly disagree with their views. Also, you want to acknowledge the concerns and perspectives of those who disagree with you and try to find common ground or shared values to build rapport. And so what do you do if you make a mistake? We're all human, we make mistakes, so I think it's important to acknowledge that you made a mistake and correct any inaccuracies. And after the interview, it's always good to follow up by engaging with the public through social media or written statements to clarify or expand your message. It's also good to seek feedback from trusted people to improve your media communication skills. Okay, so how to write an effective press release. So you always want to start with a clear and attention-grabbing headline that summarizes the announcement. So I'll give an example from the press release that our working group did. Our headline was Hamilton Councillor Wilson and Canadian Drug Policy Coalition demand safer use spaces for substance use in Hamilton. Experts raise alarm as drug poisoning deaths in Hamilton exceed the provincial average. You'll also want to write a compelling lead paragraph. This should provide the most important information and grab the reader's attention. So you'll want to go over the who, what, where, when, and why. And so I'll give an example from our press release here as well. So on February 13th, 2023 in Hamilton, Ontario, Councillor Alex Wilson and Councillor Narinder Nan, joined by the Canadian Drug Policy Coalition's Olivia Mancini and Kim Ritchie, two Hamilton social workers and activists, alongside numerous allies, to delegate during today's Board of Health meeting to highlight the dire need for best practices of harm reduction, including safer use spaces in shelters. This demand has never been more urgent, evidenced by the recent 5 suspected drug poisoning deaths at the Salvation Army Booth Center from October 2022 to December 2022. The motion was passed unanimously with a vote of 12-0 for advancing a whole community harm reduction framework. You'll also want to include quotes from relevant experts or stakeholders, as quotes add credibility and a human element to the story. So as demonstrated by the quote from Councillor Narinder Nan on the slide here. And you can always add visuals and multimedia to enhance the story. So in our press release, we included a brief 4-minute video of the success of the YWCA's Safer Use Space that was made by the Canadian Drug Policy Coalition. And then you'll also want to include contact information for media inquiries and distribute your press release to relevant media outlets, journalists, and bloggers who cover topics related to your announcement. And timing matters. So you want to send that press release at a time when it's most likely to receive attention. So we had sent our press release on the same day that the motion was unanimously passed. And again, after sending the release, you'll want to follow up with those key journalists or media contacts to ensure that they receive the information and be available for interviews or follow-up questions from the media. You'll also want to monitor any media coverage and engagement resulting from press releases to gauge their effectiveness and make improvements for future releases. And now I'll pass it over to Kimmy, who can introduce herself.
Hey friends, how's it going? So my name is Kim Ritchie. I'm a person with lived experience. I spent 15 years living on the streets in the city we were advocating in. I have worked in shelters. I'm a social worker as well. And I've been in senior management roles where I facilitated and ran shelters. So we're going to now talk about the wonderful world of delegations. So what is a delegation? A delegation to a city council refers to the process through which individuals, groups, or organizations formally present their concerns, proposals, or requests for consideration or action. This process allows citizens or entities within a municipality to address their grievances, suggest new initiatives, or seek support for specific issues. You can delegate via written, pre-recorded, or oral submissions. You must submit a delegation request, typically 1 to 2 business days before the actual meeting. They'll let you know. You can find all this information on your city's website. It's actually pretty accessible. I was surprised how much information I found. I was pretty grateful for that. So how can we make sure our delegation successfully pushes our motion or cause? First, make connections. As I'm sure you've heard many times through the course of this event, everything is about relationships. And that's a fact, it really is. So again, we emailed each city councilor to book a meeting. As a formal group, we had like legitimacy. It's so funny. Anyways, we had legitimacy and we met with 4 councilors regularly. If there's information you want a councilor to have, you can submit supporting documents in advance so they can ask questions during the Q&A segment that occurs after you read your delegation. This can also organically elicit information you want the public to have because most delegations are recorded. They're usually for us in Ontario, it's Channel 14. Speakers have a minimum of about 5 minutes, so that's like 750 words unless you're a fast talker, so be mindful of yourself. This is pretty restrictive, guys, so let me be clear. You can petition the chair for more time, but you're gonna have to have a good argument as to why. And with that being said, just be mindful that they can always say no. Keep it simple, use facts, research, not generalities. Keep your comments to the point and only speak to your requested topic. Repeat your main point at the end of the delegation. This can help councilors remember what is important to you. After you present your delegation, the councilors may have questions. Be prepared. Know your facts. Make a list of questions you think they might ask you that could be pretty tricky because there's some heavy-hitting ones and they're all representing their wards and their wards may not be too keen on your topic. So be prepared. When speaking, like addressing a question, always go through the chair. That's just proper forum. So it really helps to remember that you never address the councilors directly, and you do not get to comment on other people's delegations. They will literally just cut you off. So how do we write an effective delegation? Well, begin your delegation by stating who you are. Begin your delegation by acknowledging city staff, the committee, everybody present. When you're doing your introduction, it helps to detail who you are and why you're speaking that day. I gave them my personal background and was labeled expert, which I thought was hilarious. Clearly state the issues. Explain the issue and the negative impact it's having on community. We highlighted the ever-growing body count from the housing and drug poisoning crisis. Share personal stories. As a person with lived experience, even though I am also a social worker, I find it very easy to share my personal experiences. That comes very organically to me. I don't struggle with that. I don't feel like it affects me professionally. I know it's different for everybody, but we're gonna have to get vulnerable. We have to humanize the issue or it's not gonna be heard. Highlight the urgency of the issue and offer, this is very, very important, pragmatic solutions and explain the economic, social, and community benefits. We can't just go up there and get upset about something. We have to think strategically. And if we think strategically, organizations, institutions are more apt to work with us and not against us. Ask for support. Ask how they can support their efforts. Ask them to convene, whether we're talking about policy changes, establishing a task force, or looking at programs or funding. And then again, we like powerful closing statements, right? We want to have impact, and it's very important that we remember that. Sorry, guys, I'm disabled. She has to change the slides. So how to write an opinion piece. First, choose a topic you are passionate about and have knowledge of, because that's beneficial. Ensure it is relevant and a timely topic. If your topic is widely debated, make sure you're adding new information. Otherwise, it's not going to get published. Like, let's just be honest here. The op-ed can also be used to address news articles that are pushing like moral outrage or fear tactics. It can be used to challenge a public official on their stance or position on something. So it's really important that these are used strategically and they can be highly beneficial. Again, the word count is very minimal. So you're gonna have to be very clear, very concise. I like to think of this as an opportunity to highlight new stats as well. So in one of our op-eds, we shared data from the YWCA's Safer Use Space, where they supported 1,070 supervised injections and only 14 resulted in drug poisonings that needed to be reversed. 0 calls were made to emergency services or paramedics for medical support. Next. Setting into motion. We discussed our concerns with city councilors and then co-drafted a motion by providing our knowledge and expertise and data to support a general harm reduction framework in the community, including safer use spaces and shelters. We co-created the motion prior to delegating. Delegation was a tool to support our motion and cause. I really need to emphasize that, which was passed. As a result, city staff were directed to submit quarterly reports on overdoses and drug poisonings tracked through EMS and all deaths related to toxic drugs to the Board of Health beginning in 2023. They were directed to convene with local stakeholders, including people with lived and living experience, health and drug policy experts, to develop evidence-based harm reduction action plan to address high rates of overdose-related deaths. They were also directed to consult to conduct consultations and actions plans, specifically considering how to implement safer use spaces and other evidence-based harm reduction strategies, both in the city and in the houseless sector. The working group also met an external consultant hired by the city to provide feedback on their opiate response plan. Next. Finding the best route, research and environmental scans. A working group member shared that the city of Hamilton was revamping their shelter standards of practice and wanted the group's insight into the policy development, which hasn't been updated since 2009. This highlights the importance of building relationships because this policy will impact our homeless friends for decades to come. The city of Hamilton's shelter standard of policy has no guidelines or parameters for city-funded shelters on service restrictions. Policy on service restrictions differs significantly between shelter settings, and many are often restricted for having new or used substance-using equipment or for suspicion of being under the influence, even when they are behaving respectfully. Service restrictions, though sometimes necessary, cause harm to service users as they are banned for weeks, months, and sometimes years. Many find themselves restricted from all shelters and can only access during cold alerts. So we researched best practices for implementing service restrictions by speaking to those pioneering new modalities and conducting an environmental scan. So I looked at each major city in Ontario, and I pulled their standards of practice from their websites, and I looked at what they were doing, and we talked to other adjacent cities and asked how they were doing it, and we found that Peterborough actually had the most comprehensive plan for service restrictions for city-funded shelters. Though these are still in the making, we provided our feedback on the first draft as the city progresses towards a more formalized standardization and delivering care to those experiencing a lack of housing. We are excited as this keeps moving forward because it's an avenue to facilitate change. So what's next? The collective efforts of the working group, city councilors, community stakeholders, and peer advocacy groups led to the enactment of the City of Hamilton's opiate response plan, which allocated $667,000 towards men's shelters for 18 months to pilot safer use spaces within their facilities. However, to our knowledge, none of the men's shelters have yet to apply, despite the evident success within the women's sector. Some stated that their only focus is housing. Unfortunately, you cannot house the dead because they have already gone home. So what now? We will keep pushing forward. We will continue to meet as a working group and engage with key stakeholders. We also plan to develop harm reduction educational workshops for organizations and city staff. We plan to continue to provide guidance on the shelter standard of practice because we know adverse childhood experiences, social location, lack of access to social determinants of health, the complexities of the pandemic, silent depression, housing crisis, and drug poisoning crisis demand innovative and dynamic solutions that embrace holistic care and support. We will continue to advocate for innovative harm reduction programs, as we know it takes a long time to turn a big ship, but we have no intention of letting up as we refuse to let our houseless friends and neighbors down. Thanks, guys.
There's just some links to the community dialogues that happened before advocacy efforts and the op-eds, if anyone wants to take a picture of that. And then some of the calls to action as well. And our emails if you want to get in touch. Thank you.
Oh, that was so good. You can't house the dead. That really struck pretty hard. Hi, everyone. Okay, we're back in this really beautiful room with natural light. That feels really nice. So today I'm here as one person representing a whole group of people, healthcare workers and researchers, talking about how we engaged in some policy work last winter Just a few names there: Lucy Richard, Kate, Sahil, Carolyn, and Stephen. This was kind of the core team of people where we were constantly in communication about some of these issues last year, but there's a lot of people, and I'll list them all at the end as well. So today, research on homelessness is often critiqued for failing to reflect community needs and priorities, or to clearly support effective policy change. Oftentimes we do research in a bubble and there's no direct impact, and we really struggle to figure out how to make direct impact with our research. So today I just want to talk about one example of how a group of healthcare workers and researchers used a number of different strategies to try and affect municipal policy change last winter in Toronto. So the goals are to provide strategies with how researchers and healthcare workers can have more effective influence in policy engagement. Just to give an example of our story, so I'll talk about our story and go through that. And then really discuss how healthcare workers, researchers, and community organizations might collaborate for policy change, including what community organizations can ask of us as researchers, what you can come to us with and ask if we can help support by providing some evidence. I just want to be very clear that in every way this work just builds on the decades of work that a ton of folks, hundreds and thousands of people across Canada have already been doing. So in no way am I saying, oh, we did this last year in a bubble and this is our story. This is just one small example, but kudos to all of you in the room and everybody else doing this work all the time. So just going to describe the issue in Toronto a little bit. Last winter, so these are from winter 2022, according to the city, in 2021, we did the point-in-time count, so there was over 7,000 people experiencing homelessness. We know the problems with these numbers. There's over 8,000 people presently that are actually accounted for, but reality, there's over 10,000 people experiencing homelessness, and that is a severe undercount, doesn't count for hidden homeless, and so on and so forth. Shelter space was at 100% occupancy last year. The city said there were 8,200 bed spaces that were being used nightly. They also, because the pandemic was shifting, the public health guidelines changed, the amount of distance between beds could decrease. That meant that there was an increased number of beds that entered the shelter system or came online, so that went up a little bit. We had 2 warming centers last year with 60 spaces. When you have thousands of people with nowhere to go, that's not nearly enough. And in Toronto, we had, at the time, a minus 15 degrees threshold for activating the warming centers. Everyone knows minus 50 is incredibly cold, and people can both die and suffer from extreme ill health at temperatures much warmer than that. So this was kind of the context of last winter. In October of last winter, so almost a year ago, a group of us, frontline workers and researchers, we came together and we were really concerned about the drastic increase of people that we were seeing coming into the Toronto emergency departments who were only looking for warmth. They had no other health concern. They just needed to get out of the cold. And they were looking for help getting into the shelter spaces. We had so many people that were just in the ED, and we were also in a COVID pandemic, and we were also trying to treat lots of other people, and it just became untenable. Our hospital workers were spending up to hours on the phone with central intake, trying to get through to see if there were any beds in the shelter system, only to then be told there weren't any beds. They would maybe, send somebody to the referral center, which was full, and they couldn't get people into beds either. So you're really seeing a situation where the ED became a de facto referral center, and kind of a warming center at the same time, which really doesn't work. It's not good for anybody. Unfortunately, the worse a crisis gets and the more visible a crisis gets, it creates a window of opportunity. It's in the public eye. A lot more people were paying attention because of how bad things were. My boss kind of said, we used to fight for affordable housing, which we're still doing, and then it was fighting for shelter space. Now we're fighting for a warming center. That's how low things have got. Now we're just fighting to get people out of the cold. It was pretty bad. So I thought I would just run through what actually happened, our story a bit. It snowballed. It was really ad hoc. It was messy, but it moved, and it was effective in a few ways that I'll highlight. There were things that we were able to achieve in really small wins that we were actually quite surprised by. So we had a lot of people who were really scared for patients and clients that we were seeing, and they were really committed to making a big fuss. This takes a lot of time and energy, and we had employers who supported that. I think that's really important. We were allowed to take time, not on the side of our desks, but as part of our core work to fight for these things, and I think that that's what made this possible. So the first thing that happened is really hard to pinpoint when things really started because this is such a long-term issue, but I'll just take it back to this particular story. So myself, on behalf of our team in the Research Center, as well as the chief of the emergency department at St. Mike's, Carolyn Snyder, separately, we both sent emails to our contacts at the city, just saying we were incredibly concerned. This is what we're seeing in the ED. And we didn't know we were doing that. So that was just really random. We kind of just decided one day, this is not tenable, something has to happen, and we sent emails. The city recognized that we were both coming from the same place, connected us, and basically asked us to pull a group together who we could talk to with the city staff about the issue. So we had a good number of meetings where we basically were talking to, so this is city staff. There's only so much that they can do. They're beholden to guidance by city council and their current budgets, and this is kind of the end of the year, so it was a bit tricky, but we had a good number of meetings, and it became really clear that there wasn't anything that they could do, really, because they didn't have the funding. So they couldn't open up more warming spaces. They couldn't really do much. So we had some side conversations, and I can't stress enough how important off the record, backdoor conversations can really make things quite clear. Basically, they acknowledge that there's nothing we can do, and if you want to try a different route, go advocacy because we're stuck. So another important contextual piece at this time, that there was a change in government, or government was starting to shift at the municipal level. John Tory, there was a bit of a scandal. We went into an election cycle. Things were shifting. I think there was, my supervisor had a meeting with the mayor, and all these things were happening and things were changing. And then a new mayor was elected who was a bit more focused, who had time and energy to focus on this issue. And this eventually helped move the dial for changes that are coming up this winter. Finding a champion, I can't stress how important this is. We connected with a city councillor who was planning on bringing motions to committee to fight for what was currently happening in the winter plan. The motion was supporting more funds for warming centers and to open up a 24-hour drop-in. So we found our person, our champion at the city government who was really going to push for these things, and that's who we worked with. The previous presentation talked about delegations. We provided deputations. They sound like they're the same thing. So the committees, different committees meet and they're responsible for different things. We went to one committee meeting where about 10 or 12 of us provided deputations in front of city council. We did a lot of prep work for that. We spoke to councillors to figure out who was likely to vote in which direction, what kind of information the councillors maybe didn't know that they could use to try and sway their vote. We figured out who out of our group was going to talk about frontline experiences and personal stories that they were seeing, who was going to talk about research and evidence, and we really coordinated across that. I think one of the most powerful pieces was that we had high-ups in the hospital go and provide these deputations, as well as people who were really working with patients on the front line. So the chief of the emergency department walked in, she provided her deputation, and she started by saying she was there representing every single chief of every emergency department in the GTA. And that was kind of one of those, everyone went silent and was paying attention because that carries a lot of weight, and I think we underestimate how much power that has. We also had the director of research at MAP Center go and provide a deputation to Toronto Public Health for their meeting to really explain why -15 wasn't an appropriate threshold for calling an emergency weather event and opening up the warming centers. We developed a plan to address the issue in multiple ways. So, well, I say we developed a plan. It was a work in progress and it was messy, but we realized this had to happen. We worked with different partners, advocates who were basically saying we've been calling for these things for a really long time. Council has stopped hearing our voice. Councillors aren't really listening to us anymore because it's the same voices. And they're kind of like, oh, there's the same advocates we hear all the time critiquing us. So we really were trying to work with them to say, okay, well, what can we bring to help bolster your voice and what different perspective can we share? We wrote open letters and we had an institutional statement. And I think that this was actually really a lot bigger than any of us realized. A few of us basically approached the communications team at the hospital. I should say, we have an institution, so we have there's resources. We have a comms team. We have people working with the media. So if you work in a healthcare system or or a university, these are powerful pieces that you should be leveraging. Can go to your people and say, like, okay, what can we do? So we worked with the comms team at the hospital, who was kind of the go-between between hospital leadership and us. We figured out a language that the hospital was really comfortable with. And I think this is important because we can critique people for not coming out strong enough and critiquing enough, but having an institutional concern about the issue is really important. And even if we're not critiquing the city, even if we're expressing our concern and what we're seeing in our emergency departments, that's very powerful. Hospital leadership, this took no convincing. They were on board in a second. They were deeply concerned. The issue was huge. It's affecting the hospitals and the patients that we care about. It's part of our mission statement. That's the other thing, of like ways of convincing leadership. You figure out what your mission statement is and how this fits in. So they were on board. So that wasn't a fight, and I think that's really important. And then research to provide evidence. And I'm going to go into that a little bit, but there's ways that we have been able to now do a bunch of different studies that advocates have been using to say, see, we've been talking about this forever, here's the data. So some of the outcomes, again, not isolated, lots of work previous to us doing some of this work. But on April 26, 2023, City Council was urged to declare a homelessness emergency in Toronto. And other motions were passed as well to address warming centers and 24-hour drop-in spaces. Not for last winter, unfortunately. By the time you're doing all that work, it's January, February, and there's no movement and the budget's been spent. But this year, things have shifted. Toronto Public Health created a board of experts on housing, health, and homelessness to guide some of their work, and we have members of our team who are on that. A really big piece is that the -15 threshold was changed to -5. Evidence doesn't always lead to policy change, and the irony of this is that, again, my supervisor is senior author on the paper that everyone kept pointing to, saying people die at warmer temperatures than -15. That was published in 2019. So, and it had been presented to City Council already. They knew this. It wasn't new evidence, but it hadn't been taken up and nothing had been changed without some of the other pressures that lots of other people were doing and the deputations. So again, window of opportunity, things shift. Evidence doesn't lead to policy change on its own. The winter plan this year is going to be a lot more robust. There's 170 spaces instead of 60. There's a 24/7 drop-in space that's being opened. There's a lot more warming centers that are being opened in different parts of the downtown core, so it's not just out in the suburbs. Again, these are things people have been calling on for a really long time, but now we're shifting back and things are changing again. We're also looking at, the hospital has kind of talked about looking at a process for institutional statements. This was the first time this happened. There was no template, there was no mold for how do we get the hospital to make a statement as Unity Health Toronto. So that's 3 hospitals, it's quite a lot. And they have a lot of power. So this has kind of opened a door to, okay, in the future, what are some different ways that the hospital can come out and can be vocal in ways that aren't critiquing the people that they also work with, because they work with the city quite a bit. So how can we do that? Just want to highlight some research studies because I think this is really important. Our team published a study looking at ED visits for cold weather-related injury in Toronto. This is published, and if you email me, I can send you a copy if it's behind a paywall. We found that people experiencing homelessness are 14 to 18 times more likely to visit the emergency department for cold weather-related injury than housed people. This is 14 to 18 more times. So when we're talking about we need evidence to show that the obvious thing that if you are outside and it's very cold, your health is going to be impacted. There were no numbers that we could point to in Ontario. So this is one piece of evidence that's being used to really show, okay, now we know what the rates are actually. We also need numbers so that people can advocate properly. So generally people are really only moved by numbers, right? That's what gets things going. Our team really wanted to look at if our hospital, to start with, was accurately identifying all the people experiencing homelessness that at the time of discharge from the hospital, we were able to identify that they were experiencing homelessness. We just wanted to know numbers, who was coming into our hospital, who was being discharged that were homeless. So we're running a program in the hospital that supports folks experiencing homelessness and post-discharge. We've supported 353 people who we 100% know are experiencing homelessness, and we basically use that as a group to compare if the hospital was also identifying those folks as experiencing homelessness or if there was a discrepancy. What we found was that at our hospital in the coding for, anyways, I won't get into the coding stuff, we're missing 40% of people from that group. That means that we really don't have an accurate understanding of how many people are experiencing homelessness. And when all of that data goes to the provincial government, their numbers then are quite a bit lower about who we're identifying as experiencing homelessness. There's a study upcoming, and I'm not allowed to tell you what the results are because it hasn't been published yet. We're going to do a preprint really soon, so it is coming out really soon. But the goal was that we looked at trends in emergency department visits during cold weather seasons. So basically, we wanted to really understand how many people were coming into the ED only seeking warmth, essentially. People that were coming in and they didn't have a serious health issue. It's very complicated in terms of there's not an indicator for that. So our brilliant data person, Lucy Richard, who's not here right now, but she's happy to talk about this with anybody else, but she, with the team, developed a couple of different proxies, proxy indicators to figure out this number. And I think what's really important is this highlights how we can use existing administrative health data really quickly to figure out numbers and to provide evidence for things that are really important. So the paper's coming out soon. Watch this space, as the kids say. Just a couple things around current challenges. Even if we're achieving success in some of these realms, this isn't really the battle we want to be fighting. We don't want to be fighting for warming centers. It's really sad. We need longer-term solutions, and that's where all of our energy should be focused. We're also seeing a lot of refugee and asylum seekers. They're landing at the airport, they're coming to Toronto, and then they're sleeping outside on the street, outside of our downtown referral center. That is the current situation. We've moved hundreds, I say we, the city and all the organizations have moved hundreds into churches, and then slowly moving those into other cities. They're going to London, Niagara Falls, different spaces. But winter is coming, and this issue hasn't been resolved. So this needs a lot more attention as well. We're lacking gender-appropriate services across the board. There's been so many sessions on this. I'm not going to go into it again, but this is just a huge gap. And different city departments operate differently. So the folks who are doing the clearing of encampments aren't necessarily connected to the shelter folks running things. They operate in silos, and they don't always talk to each other, which I was surprised to learn as well. So we really need to be targeting different groups when we're doing some of this advocacy work as well. I just want to plug that the current winter plan, while better, is still not enough. A couple of lessons learned, because I know my time is running out. As healthcare workers and researchers, we have a lot more power than we realize we do, for better or worse, whether it's appropriate or not, and we could critique that as well. In our current context, we just do. So find your PowerPoints and leverage them as you're able to. When the chief, like I said, when the chief of the emergency department starts their deputation that way, everyone was listening, and it's what got picked up in the news cycle. And then the general population who's reading this, who maybe wouldn't have been on board, is seeing, oh, the chief of every emergency department is freaking out about this issue. This is something I should be paying attention to as well. Find your back channels for communication to policymakers. Figure out who you know, figure out who your boss knows, any kind of connection you might have, and just work those angles. A lot of councillors also don't know the details of the issue and how it is going to affect their constituents. So really targeting, okay, this is what this might look like in your area for the people that are voting for you and that you're worried about. So you can kind of tailor some of your conversations. I got a lot of messages from community service providers and organizations when the institutional statement came out saying that they finally felt that healthcare was showing up to the table, and they felt really supported. We didn't want to step on toes. We really wanted to help bolster those voices, people that were already fighting. And the response we got back was that this was huge, and we need to keep doing this because it really helps get their voice out there as well and have people pay attention. Know your policies around institutional affiliation. It holds a lot of power when you're able to sign an open letter and have your hospital attached to your name. You're not always allowed to do that. We're allowed to make statements based as individuals or as researchers, but your institution doesn't always support that. So figure out what those institutional policies are, and if there's room for navigating those pieces, work on those as well. There's unique, fast, and relatively easy ways of using existing data to provide evidence. Lucy is going to be the person to talk to about that. I can put anyone in touch with her, but it happened. The first paper was mobilized within a month. She had the data, she wrote it up, and it was ready to go in about a month. So it can happen really quickly. You don't always have to apply for big grants and get REB approval when you're working with existing data sets. Get into the media. I can't stress this enough. Again, as doctors and researchers, I think we have an obligation to put our face out there more and talk as experts, again, for better or worse, or experts in a certain area. But that is what was holding some power now, and I think we need to be using that to bring up the voices of other folks and what the concerns are. And just use all the different strategies. There's so many different ones. This is part of the core group of people that were really involved. We were on WhatsApp chats every day. This is the part of the core group of people. I just also want to, the other hospitals, Mount Sinai, University Health Network, and Unity Health Toronto, who I work for, everybody was on board. This wasn't, we didn't have to convince anyone that this was something worth fighting for. Everyone was really much on board. And yeah, these are the core groups of folks who went and provided deputations as well. Thanks so much.
Yes, there it is. How do we move them? The buttons here.
Okay.
4, 6.
You start.
Okay. My name is Michael Shapcott. I'm a visitor here in Halifax from Swepnikulu, the traditional unceded territory of the Swepnik people. When I moved there about 5.5 years ago, started taking language lessons, they generously offered me some words that I'd like to bring to you. One of the things I discovered was there are 13 ways to say thank you in Swepnik, and that is a sign of the generosity of the spirituality and culture of the Swepnik people and indeed Indigenous people. And one of them is Kukstichu. Kukstichu. Can everyone say Kukstichu? Kukstichu. So Kukstichu means thanks to you, I am so fortunate. And it's a demonstration of this notion that there's a reciprocity amongst all of us. And it's expressed in different ways in different faith traditions, in the Christian, Jewish, Muslim, in the Eastern faith traditions and so on. But this notion that we owe a duty of love to each other is a very powerful notion, and how that's expressed in terms of advocacy and how it's expressed in terms of service is what we want to talk about. And the Faith Communities for Homefulness Network is a new allied network of the Canadian Alliance, and I'll talk a little bit more about that. But first of all, the man of the hour. So when I said it would go that way, okay, we'll try it this way. There we are. Brian.
Okay. So we're moving from downtown Hamilton to Queen Street, where St. Michael's Hospital is. We're moving from very, very particular kinds of contexts of homelessness and advocacy around homelessness. And we're going to, with some fear and trepidation, step back. Step back in a way in which David Coletto helped us step back this morning. What's the broader picture in terms of attitudes and feelings and anxieties around housing and homelessness in our time? And then how the Ottawa group gave us a video that reflected on home. When I looked at The Guardian this morning, I read this quote: "If there's hell on earth today, its name is Northern Gaza." Its name is Northern Gaza. Now, there are folks in this room who have experienced hell on earth here in Canada. And we begin every morning of our conferences with Indigenous spirituality, because the hell on earth for so long was the colonial genocidal policies in relation to our Indigenous siblings. And that's appropriate. That's right. I also note that we begin with spirituality every morning. And that is something that our network, the Faith Communities for Homefulness Network, wants to encourage in a very broad and multi-faith way, with a clear acknowledgement of our indebtedness to our Indigenous neighbors. But if there's hell on earth today, its name is Northern Gaza. And I have been here throughout these days, and Gaza is always on my mind, where what we have going on is a genocide born out of a context of displacement and domicide, the murder of home. And so when we want to talk about these issues of housing and homelessness, we want to get to the heart of what we mean by home, and we want to understand the crisis of homelessness in broad kinds of contexts. David Coletto said this morning, housing is at the center of everything. I like to suggest home. That's true. Housing's at the center of everything. Home is at the heart of everything. So we need to set homelessness within a deeper and wider context. We need to actually move even more upstream in our analysis, upstream to not just the policies that created the homelessness crisis, but the cultural context and the ideologies and the spiritualities, and maybe even really distorted spiritualities that created the context, the cultural context for those policies. Policies don't happen in a vacuum. A crisis of homelessness is a crisis of geopolitical displacement because of war, climate crisis, economic failures. It's a crisis because of refugees movement from throughout the world. The climate crisis and ecological despoliation, those are crises of home. What is the climate crisis but the overheating of home? The house is on fire. Somebody once said, what's the point of having a good house if you don't have a decent planet to put it on? If our alienation from the land is so deep, okay, I'm preaching, I understand that. If our alienation from the land is so deep, then we have no resources for homemaking because we are fundamentally displaced from the earth itself. So we need to think about the destruction of home in broader connections and broader context, of this disconnection from place, from land, from ecosystems. And our Indigenous siblings tell us that this is at heart a spiritual matter, spiritual homelessness. You know, Jesse Thistle's wonderful book, talking about spiritual homelessness. And any discussion about Indigenous homelessness is always focusing on spiritual homelessness. And you know, if it's true, and I think it is true, that we live in a culture of scarcity, that is really, really bad news for homelessness. You see, the whole notion that has failed was the liberal notion of a social safety net. And we have a social safety net because we should not have people who are homeless in a culture and the economy of wealth and a growing economy. But what happens, so you have a moral responsibility because there is excess finances, excess resources, capital, land, excess that we can then use to bring people up or to catch them when they fall. Not asking, why the hell are people falling anyway? And what happens if there isn't the excess, or even if there isn't the perception of excess, but rather the perception is of scarcity? Well, then your sense of moral responsibility on a broad societal level is out the window. So one of the things that we need to do, and I see it happening here, and I love it, is we need to be talking about homelessness as a moral and a spiritual crisis. That means we need to be moral and spiritual leaders to bring us beyond that. So, let's do a quick word association. I'm going to say a word, and you can shout out to me whatever comes to your mind. I say home, you think? Warmth? Family. Safety. Belonging. Peace. Identity. Stability. Neighbors. Sorry? Safety. These are all terms that immediately come to mind when we say home. Often in context with folks with lived experience, somebody might have said coldness. Someone might have said rape. Someone might have said violence. Someone might have said hunger. And often in a group when I do this, at a certain point we get all these positive words, and somebody, pricks the balloon, and out comes, that's all lovely, but that wasn't my experience, right? But we need to engage in reflecting on what is home. We called it, I think, in our, how do I find, there it is. So we're going to come back to that. We called it in this thing a theology of home. That's because I'm a theologian. But we could call it a phenomenology of home. We could call it the characteristics of home. What is home? And it seems to me that we all work with some sort of functional definition of home. We all work with home, some understanding of what home is. And I mean, Aaron Day's book, lovely book. Aaron, you have a functional definition of home running all the way through. You never argue for it. You never defend it. And that's the way a phenomenology of home works. When you start to describe home, I asked somebody who was doing something like this, I said, how do you know if your phenomenology, your characteristics, how do you know if it's true? And this particular scholar said, well, I kind of look around and see how many heads are nodding in the room. And that's about right, So I like to suggest some characteristics of home, and I offer them as sort of intuitive recognition. And I want to suggest this, that the deeper your understanding of home, the more profound will be your analysis of homelessness, and the more creative will be your proposals for homemaking. Your housing proposals will be more creative the deeper your understanding of home. I just got an amen. Now we're talking. Okay. So I would, let's not get out of hand, folks. This is not a Pentecostal assembly this morning. So I want to suggest 8 characteristics of home, somewhat in some order, and I don't have a slide, but I should have made a slide. The first thing is I think home has something to do with permanence. That's why where I am the chair of the board, a place called home is a shelter, and I'm always saying we need to live up to our name. And being a shelter is not living up to our name. Because being a shelter is by definition transient, it's not permanent. So permanence, a sense of a security of tenure, I'm not going to be thrown out. I'm not going to be evicted. I have this place, and in this place, I can have a sense of permanence. Home is also, as we like to say, it's not a house. A house is not a home. But a home is a site, secondly, of dwelling. It's a site of where we have deep relationships with our neighbors and with the built structures, with the geography. A sense of dwelling in this place. It's a place of deep meaning and psychological resonance. Thirdly, home is, as everybody who comes to this conference with lived experience will tell us, is rooted in story. You know, the word blessing came up in that session we were in, Aaron. You know, the blessing of these stories that folks share with us. Home is always storied. Home is where memories are made, including terrible, broken memories, and those memories need healing. Stories are formed in home. So my lived experience of homelessness, apart from being raised in a broken home, I couch surfed for a few months after my marriage broke down. And I'm gonna cry. And when I would move into a place, I moved into one place, we had a futon, a table, and 2 chairs. Me and my 9-year-old son. What did he bring from his mother's place? The place where things were all broken now for us. He brought a box with sports trophies. And he put the sports trophies up. Because these are the memories of homemaking with his dad, right? It was sort of, as long as I got the sports trophies, then I got the story, and I got my dad, we can still be home. Story is at the heart of homemaking. And so therefore, amnesia, a sense of forgetting, is also a sign of homelessness. Home is a place of safety, a place of rest, of regeneration. Make me a bed of fond memories, make me to lie down with a smile, sings Bruce Cockburn. A place of fond memories, a place of safety where you can lie down in that safety, a place of contentment. Those who are never content in their houses, those who are always striving to get the bigger and bigger and bigger house, are never home there because they're never content. There's something about an economy of unceasing growth that is by definition an economy of homelessness. Home is a site of hospitality. It's a site of safety where you've got a door and you can lock it. But it's a door that can be opened. And where there is no hospitality, where there's no possibility of hospitality, there is no home. When all you want to do is build the walls in your xenophobic fear, and there's no hospitality, there is no home, indeed no homeland. Home is a site of inhabitation. So dwelling and inhabitation. By inhabitation, I mean home in place and home in neighborhood and home in land. It's a place where you notice the migrating birds. So my friend Kenny, who used to have a squat in Rosedale Valley, Kenny was homeless living in a squat, but Kenny noticed the migrating birds, and he noticed the coyotes coming down the Don Valley, and he noticed salmon in the Don River. In many ways, he was way more at home in his place because he inhabited his place than were the condo dwellers just a few blocks away. Home is a site of orientation. It's sort of the axis, it's the center of life. And because you're rooted there, you orient your life from that site of home. And I think that's partially why folks on the street often are so disoriented, because they don't have home. There's mental health issues, there's drug issues, but there's a sense of disorientation. And finally, home is a place where you belong. Home is a site of being known and being beloved. It's secured by bonds of affection. You belong to this place, and this place belongs to you. And that's so incredibly foundational. Now finally, and I've lost total track of my time. How am I doing here? But do I need to stop now? Okay. That was enough.
I love telling Brian that because he was my theology professor, and I love telling him to be quiet. So I just want to take a minute or two to talk to you about the Faith Communities for Homefulness network. And so in introducing myself earlier, my name is Michael Shapcott. I serve as a deacon. I'm an ordained deacon in the Anglican Church of Canada and licensed in the Diocese of Kootenay. I serve a ministry that includes the Sereno Center, which is a retreat center, and a little shared ministry, United Anglican Church. About a year ago, I was, some friends of mine were developing some affordable housing in a little village about 20 minutes down the road called Chase, and they were having some difficulty, the usual sort of NIMBY stuff, disguised as zoning requirements that were being loaded on. And so I put on my collar, and to my clergy colleagues, I generally only wear my collar when I'm meeting with politicians. Anyway, put on my collar and reminded them of their moral duty. So I wasn't there to talk about the statistics that the researchers do showing the huge housing need, although that's really, really important. I don't go there to talk to them about the complexities of planning law and the human rights law's implications and so on, but simply to say that we owe a duty to our neighbors. And that duty is a duty of love, and we express that duty of love by doing things like ensuring there's adequate affordable housing. And, I'm happy to say that a year later, the foundations have been poured for what will be a 32-unit homes for folks in the village of Chase. We've got the services in, and we expect by the end of the month, it's a modular construction, the first two, the fourplex and the eightplex will be built, and the other two buildings will come afterwards. So it's important to use the moral language, as Brian mentioned, and one of the things faith communities have been doing for many, many years in Canada and around the world is expressing this duty of love, this sense of reciprocity that we owe to each other in practical ways. Sometimes it's in providing food, sometimes in providing shelter, and we've learned a lot of things over the years. Back in about 12, 13 years ago, a small group of us got together to imagine what it would be like to have a national organization committed to ending homelessness. And as one of the founding members of the Canadian Alliance to End Homelessness, I was very concerned that we had the moral voice there, as well as all the other important voices that are there. And we had just created at that time, a multi-faith alliance to end homelessness in Toronto, and I will get wrong the entire list of people, but Indigenous spiritual leaders, Anglicans, Jewish people, Muslims, Baha'i, Buddhist. It was great. There was about 30 different faith traditions that were represented. And we got together and agreed on some basic principles. One is that we need to listen to the people that we are advocating on behalf of, and they are our leaders in terms of lived experience. We agreed that service was and is very, very important, and raising our voices collectively. So I'm not going to say anything more about that because I now see Sam is moving here. But I want to say to you that after 10 years of struggling, we are launching the Faith Networks. Why is it not appearing there? Okay, so I guess that's another sign to shut down. The Faith Communities for Homelessness Network, and last night a few of us met. I just want to say to you that if you are interested, look on the Canadian Alliance to End Homelessness website in the coming days. There will be information posted. We are recruiting people to serve on a steering committee to develop a plan of action. We have some substantial funding generously donated by Porticus Foundation, and we're looking to continue both to learn from the practical experiences of faith communities in the last century and more here in Canada, and also share those practices, develop toolkits to help faith communities to be continue to be partners in the campaign to end homelessness in Canada and ensure that the homemaking process is robust and deep and meaningful. Thank you, Sam.
Well, I feel like I've been drinking from a fire hose because there's a lot of richness, and I want to make sure that we give you a chance to ask a few questions. Advocacy is so interesting, isn't it? I mean, you've talked about it from a number of different angles, and I stand here as somebody who's done, my communications team in Montreal tells me I've done more than 900 media appearances since the start of the pandemic. So that's a lot of interviews with reporters, and my youngest daughter is a CBC reporter in Quebec City, and she calls me a media whore. Which she says means, Dad, you're always available. So I don't know that that's a compliment or an insult, but I think advocacy is so important, and to the extent that you're interested in it, there are a wealth of people here at this conference who you can connect with. That's why I always promote the app, like it's got a list of everybody and their contacts and so on. You can connect with them and learn some things about how you can do advocacy more effectively in your communities. So I'm going to say, hey, if you've got a question, this is the time. These are the experts here today. Let's ask them questions. We have a few minutes left. Stick your hand up. Our wonderful volunteer at the back. Yes, first question is at the back, so that's perfect.
Hi, I'm Gloria. I'm from Winnipeg. So with all this research...
Just hold the mic real close.
Hello?
Yeah, real close.
I didn't hear any much of addictions within like healthcare. I know back in Winnipeg, I seen myself. I went to emergencies 4 times within the last 2 weeks, but I'm glad I'm getting well. But when I was there, I was kicked out because they thought I was almost kicked out because they thought I was homeless. I said I'm here for medical attention. So when I was speaking to most of the people inside there, the emergency, they were wanting detox. So like what's, I'm just curious, like because there's like not much addictions being talked about.
You're asking about, is there advocacy going on around detox?
Yeah, detox and addictions.
Somebody want to speak to that one? Make sure you have the microphone, eh?
So it's funny you mentioned that. Like our focus, of course, is homelessness today and talking about how people who use drugs are treated within the shelter system. And is this thing on?
Yes.
Okay, sorry. It's how are treated within the shelter system, but let me be clear. As a person with lived experience myself, I've faced severe discrimination at the hands of healthcare practitioners who were believing they were gatekeeping me from a bed when I just needed help. And I also have endured that as well. But as a white cisgender woman, it's still different for me. And I recognize that too, and I want to honor that as well. I want to say that it's not getting better. And I'm just going to be very candid here. Yes, hospitals always encourage detox, but detox beds are often full, or a person doesn't feel in a place that that's the right remedy for them. And 99% of the time, I hear the words drug seeking used by healthcare professionals, and it makes me sick to my stomach, to be honest. And I wish that we could change the language. I think we need to start co-creating a language that is accessible. I think we need to reimagine trauma-centered care and not trauma-informed care. I think that we need to understand, too, like the healthcare sector, and let me be clear, I'm not defending it, but it's also, specifically in Ontario, is being stripped. and they're overworked, overtaxed, and it's hard for them to even attempt to provide appropriate care if they had the training to begin with. So I think if we're going to tackle something like this, we'll have to take a multifaceted approach. I recently joined a social prescribing committee with this incredible agency that's implementing it in Hamilton. And we also have this work being done in Hamilton now that is more groundbreaking, but they're severely underfunded for that piece. And I just hope that as we move through, that we imagine education for healthcare practitioners, that we stop putting doctors in the position where they believe themselves to be gods of their wards, and I really think we need to move away from having them on these pedestals and humanize and demolish these hierarchies within hospitals that put peers at the bottom, social workers just above them, and then your nurse hierarchies, I can't remember them, I'm sorry guys, and I really think we need to eradicate those kind of power structures and really get deep into it. The advocacy being done there is happening in different places. Is it happening yours? I can't speak to that. I hope it is. I hope there's people coming together and coalitions and challenging and going to the medical ombudsman and organizing and coming together. In Hamilton, I see it happening. I do. And it's nice because I'm so tired of sitting with clients and watching them face the same damn discrimination I did 13 fucking years ago, because it's exhausting. So we need change to happen. With the housing crisis, a lot is happening with the cold centers where emergency wards have to assess if a person's there because they're ill, because they're homeless, and they're trying to stay warm and not freeze to death, which is awful. It's awful. When we don't have warming centers and we don't have places to go, I've literally told clients to go to the emergency department so they don't freeze to death on the street. And that's an awful place to be in. And then to have them go there and just be treated like shit, that's not okay either. So we really need to actively talk about this and actively build solutions and stop coming from this reactionary place where we're like, oh, winter's coming, we better get a warming center together last minute. This isn't working. We need to be strategic and think long term about how we're going to keep people safe until we get them housed, but we also need to address the systematic discrimination and racism and prejudice against people who use drugs within these systems, or we're going to keep hitting the same damn wall decade after decade after decade. So I hope that people
I think you have some competition in the preaching department.
Well, I just want to say that sometimes news from the other side of the Rocky Mountains where I live doesn't reach the rest of Canada, but we have, of course, a drugs overdose crisis that has been declared by the government a number of years ago. But we actually, there's some interesting and very positive examples that we've been part of. Recently, by recently I mean about 3 years ago, we opened some new housing for people who were experiencing homelessness in a little city just down the road from us called Salmon Arm, and has safe injection on site, safe inhalation, safe drug supply, all of that. And I may say the doctors are not gods there, but they are. They understand that they're there to deal with people who are facing health challenges, and they're not there to moralize or to do the abstinence approach. And so I think there are. I know that it's not unique. There are other places as well, and I think it does come to the point of changing the lens from saying that you're different than me because you're using drugs or something like that. Therefore, I want to keep you at a distance, and I want you to start to look like me. To saying that there's more that's alike in all of us than there is different, and if people are facing particular challenges, then let's address those challenges in a non-judgmental way. And the housing stability in this project's 38-unit building, what we call a high-rise, I think 4 stories. The housing stability, nobody has left the building, and everybody is well supported and getting access to what they need.
Let's take another question. I want to get as many of your questions in as possible, so that you've got the microphone. Talking stick.
Hi, thank you. On Hot Squaws, good afternoon, everyone. My name is Deborah Baker. My ancestral name is Ghana. I'm from the Squamish Nation in West Vancouver. And I'm really grateful to be here with my colleague, Margaret. We're from Van City Community Foundation, based in Vancouver. I don't know if this is actually working. Oh, there we go.
Just keep it nice and close.
Okay, thank you. Excellent presentations, all of you. I was appointed to Vancouver Coastal Health Board 3 years ago. And to hear what you're saying about the healthcare system is very important for me. Because those stories that you shared, I don't hear them at that high level. And I really believe we need to hear that. I'm not too sure how many of you heard the news, but I cannot tell you how excited I am to know, and I lived in Winnipeg for 4 years, that the Premier of Manitoba is Wab Kinew, who is Indigenous, and the first Premier in Canada to be Indigenous. So what we heard here today was a lot about advocacy, which was very profound. A lot of your suggestions, recommendations, and the actual work that you did was it changed the dial a bit. So that's why I'm thinking that we need to help everyone across Canada. And we need to step up. And I know it's out of our jurisdiction and probably politically incorrect right now. But from hearing what you just shared, that same scenario happens across Canada, especially to our Indigenous brothers and sisters and people of color. And so at the end of the day, what we heard by you sharing your truth, we need to take it to the next level because we have that awareness now and we need to take action. So after this session, I'd like to get your contact information and I'd like to follow up. But I really appreciate everything that was shared today, Sam, and this conference overall has been very fulfilling, a lot of amazing information, and we're looking forward to hopefully going back to Ottawa next year. Thank you.
Thank you. Maybe a question near the back there, yes.
Yeah, thank you.
Just stand up so we can see you.
Yeah, sorry. My name's Jason. I'm from Saskatchewan. I think all your messaging was really good, but I feel like there's a piece missing, and it's the long-term strategy around advocacy. It seemed like everything was really reactionary and mobilizing, and you were really good at that. But we've seen this around the harm reduction movement in the prairies, where we had a lot of movement that was focused on ongoing education to the public through social media and traditional media. And I just wanted to ask about like your opinion of using social media, like Toronto, for example. I can think of probably like 10 different Instagram and Facebook accounts that have, you know, upwards of 1 million followers when you combine them all. The using of social media to educate the public on an ongoing basis and report back on the initiatives, because I feel like a lot of times we get these successes where an initiative gets implemented and then the public says we don't hear about it. You know, and so in order to actually get those policy changes, and we see right now the Conservatives are really taking advantage of that void, and they're starting to dictate the narrative because there isn't an ongoing public education and advocacy strategy around this. And so just your thoughts on utilizing like you guys sound pretty mobile and pretty dedicated, but utilizing that to create ongoing education in the community for your various topics so that you're not scrambling every time, and that the next ask isn't just trying to get them baseline education level, but your policymakers have that baseline because their constituents have that baseline and they're holding them accountable. So just your thoughts on like an ongoing strategy for keeping the momentum up.
Yeah, it's a good one and good question, and I don't know who wants to comment on it. It's interesting. Tim quoted me this morning. Did you hear him? That I always say, I repeat this over and over again, that public policy moves at the speed of public opinion. And so one of the challenges we have is to alter the course of public opinion. And I think we are in a good space right now to do that. I see the public being receptive because all of a sudden the challenges into the general public that used to strictly be in the rundown areas of our downtown large cities have migrated out to every small town, every suburb. People are seeing, people are feeling, people are knowing. And so we're in a good position to actually have a longer term approach. Interested in any of your thoughts on long-term advocacy?
First, I want to acknowledge the fact that I'm the former executive director of the National Overdose Response Service, so I'm well connected to a lot of harm reduction agencies across the country. And I know Saskatchewan's premier said that they will not support harm reduction, and that you guys within the harm reduction movement are facing one of the biggest regresses I've ever seen. And my heart aches for you, and it aches for your communities. And I deeply support the efforts of your ongoing harm reduction activists and the social workers doing harm reduction in the shadows, trying to keep people alive, and will continue to do so. Here's the thing, right? We are battling against, and same with our situation, we went and we did everything we're supposed to do, and city was on our side, and we got all this money for these men's shelters, and because of their adherence to like religious ideologies and these abstinent-based prohibitionist ideologies, they don't want to move, and people keep dying. Evidence doesn't do it. We have 39 safe injection sites, 38,000 people dead since 2016, and we have data that says since the 2000s, not one person has died in a safe injection site, and yet we can't get more. And yet we have entire provinces, that's an irrefutable stat, we have entire provinces saying no. Because at the end of the day, it is social, political, and economic will. We know harm reduction has a cost-benefit analysis of every dollar spent in Australia, it's 7, every dollar spent here, it's 4. And that data is 10 years old, so we know that that has very much changed and still very much prevalent for cost-benefit analysis done by health economists. We know all these numbers, and yet we're still fighting against 200 years of prohibitionist and abstinent-based ideologies that keep permeating the war on drugs set by Reagan and the countless people dead globally and the rise of the drug cartels because of prohibition. The ideas that drug users are villains that need to be medicalized and criminalized and pathologized and denied access to healthcare, denied access to housing, denied access to everything in between is absolutely appalling. Social media becomes a pinnacle moment where you can create memes, vines, and use TikTok to support momentum, to gather and collect and find your allies, especially with Canada's unique geography, which kind of spreads us out more, which does pose some challenges, but we can find them. And I would encourage you to use them. I would encourage you to keep pushing forward. I had a chance to talk to a man I respect a lot, right, Donald McPherson, and he said something to me because I'm struggling with this as well, with the pushback that we're seeing, the regression in rights we're seeing in the states that will come here, the threat of an onset of conservative government which will, compromise all our funding. This is going to happen. So what are we going to do? How can we stand up, and how can we stop the barrage of the regression of all the work that we've done and all the momentum we gained? He said to me, oppositions come and go, Kimmy, and we're still moving forward even if it's like 10 steps back. So that's what he said. He said, oppositions come and go. And I sat and I thought about that for me because it's such a simple response. And it's true. We just have to keep pushing forward. It's not going to get easier. This is going to get worse. We can come and we can talk and we can throw our numbers around and we can come up with innovative programs, but unless things really profoundly change, which they're not going to right away, it's going to get worse. But I would stay here and say, as your ally and as your friend, that we just have to band together until we get through it, because eventually it will get better. And if we just keep pushing and using social media and finding our people and getting those people in ambiguity to see the light, we'll get there. It takes creativeness, by the way, if you're wondering.
Creativity, yes. Go ahead.
Yeah, so thank you very much. I am a PWLE, and thank God there, but for the grace of God go I. So I would refer you to the work of Doctors Belmar and Sampson in Timmins, Ontario, who have completely transformed the emergency departments, and they also pioneer Sublocade as an alternate to methadone. But I'm a Salvation Army officer, and our facilities are high barrier because that's our train tracks. We don't have the funding or the capability to deal with the issues. So my question is, bringing the counterbalance, and believe me, as a PWLE, I'm all for harm reduction. That is, with all due respect, not what I'm saying. My question is around safe space, trigger-free zone. We have a city where I live with a safe injection site, and we direct people there. But there is those who wish to avoid the triggers. So what's your impression on the balance of that?
No, absolutely. So I'm a person who practices abstinent-based harm reduction or abstinent-based recovery, right? So I have 13 years in sobriety. But I'm also an advocate of harm reduction. And here's why. Because they're not dichotomous. Recovery is a gorgeous spectrum where people use opiate agnostic therapies or cannabis as an exit drug, or may have success with one substance and not another. To look at it through a dichotomous lens is to fail a whole section of people, and it's not acceptable. And here's the thing. When I was in abstinent-based only spaces, people were still actively using. They were still there and shooting up my favorite drugs. Let me be very clear here. I had to make a cognitive choice. I would argue that when we have things out in the open, we create the ability to have honest conversations. Yes, there needs to be a little segregation. You can have 2 separate floors. You can get creative with it. It's not that hard. But when people stop drinking, they're still around bars. When people stop gambling, you can still go on an app on your phone. When people have sex addiction, there's Tinder and lots of other dating apps. So at the end of the day, addiction isn't so much about exposure to triggers as it's about looking at the nuances or the function behind a behavior. I can tell you right now that I grew up in the cultures of criminality and poverty. My mom was a drug dealer, my dad was a bank robber, and all the nuances around that. And those are the things I grew up with. So it was the first childhood experience, all the nuances around that. What's the function behind it? Why does that person feel like they need to gamble their life away? And I don't think we look at the neurology around that. We have literally dopamine slot machines in our hands every day that nobody can put down. Why? Addiction is far more complex and nuanced than it is to describe it as just a simple adherence to the physiological effects or the euphoric effects of a substance. It goes well beyond that because we're in a realm of escapism because our society is so intolerable now to live in. Let's be clear here. There has always been a huge correlation between suicide rates, overdoses, and external stresses within a society. We've seen the studies since, I think, the 1800s when that first sociologist started studying suicide within industrial urban complexes, man. So I don't know. When I think about these things, I would argue that within spaces, when we have honest conversations, honest ones, we're going to have less death, less triggers, and open up conversations. And here's the thing. We did get the funding. Our groups advocated, and the Salvation Army, unfortunately, is one of the ones who haven't accepted it, despite the fact that they had success in a safer use space. During COVID, they had to implement an emergency one for 6 weeks because of a bunch of positive COVID cases, but now there's $667,000 on the table. And I've done fundraising. I've written $4 million in grants, easy, as an executive director. The fact that they're not taking that money says a lot. It tells me that we're in a society that refuses to see drug addicts as human beings, and it's unacceptable.
Well, I would just counter, we do give drug testing kits for opioids, and we do give all of Narcan, and we do give safe supply. We have all of that in our ministry.
I should probably be clear, too. Salvation Armies differ greatly from city. The one in St. Catharines, amazing. Amazing work they're doing there. So, again, this comes down to leadership and ideologies, but I don't have time for your ideologies or anybody else's that tells me that my friends are going to die. So we need to get creative. We need to start finding some middle ground here because at the end of the day, this is not just a housing crisis. This is so much more nuanced than that. And until we're willing to accept that and acknowledge that, we're going to keep burying people.
No, I'm gonna bring this one to a close now because it's time for you guys to get lunch. But what I'd like to do is just acknowledge our panel. And also, I think, unless you are in a hurry, feel free to come on up here and have a conversation with them. This is it's a very informal thing, but this is part of the experience of a workshop. So please come on up and chat. And thank you for being here.